So this is a 69-year-old gentleman who presented to our hospital with non-ST elevation MI. He has relevant comorbidities.
We don't see the slides.
And like hypertension, dyslipidemia, and he's a former smoker. And he presented last week, in fact, with symptoms of chest pain, and the EKG showed no significant abnormalities, as you can see on the screen. He was treated with DAPT and statins. His lab tests are unremarkable, except for mild thrombocytopenia, and he underwent echo evaluation, and it showed no wall motion abnormalities. This is the EKG, like I said, no ischemic changes. And this patient underwent coronary angiography, and as you can see here, he has a tight lesion on the RCA, on proximal RCA. There's another lesion on the mid to distal segment. We can see also on fluoroscopy that the vessel is calcified. And here in another view, you can appreciate the lesions that this patient present. And he also has a tight lesion on the mid-LAD. In fact, it's a bifurcation lesion. We discussed in terms of clinical and anatomical risk assessment. The Simplex score is low to intermediate risk.
So this is a double vessel disease patient with normal LV function.
Yeah, and
perfect. Tight lesion in the LAD, tight lesion in the right.
We don't have any clue about who is responsible for the acute ischemic syndrome. Maybe the LAD was the culprit lesion because there are some disturbance of flow in the LAD. So we discussed like we did for all cases, and he underwent PCI of the LAD.
Can you go back with the slides, please? So if you talk to a surgeon, a cardiac surgeon, in a case like this, it seems to me a good case for surgeons too. So how do you make your choice to indicate this PCI or CABG in a patient like this?
Well, I think in this patient, he presented with acute coronary syndrome, two-vessel disease, like you said, normal LV function, no diabetes. I think it's fair to consider PCI, ad hoc PCI.
But the surgeon, the cardiac surgeon, agrees with you?
It's difficult. I think so.
Let me ask you, Jose, if you are I know you work in the emergency room too.
Yes.
So if you're there, we have seen a patient like this, you send this patient to cath lab and they call you, do you think we should ask surgeon to do a bypass surgery in a patient like this, or you prefer PCI?
I would prefer PCI. As you can see, it's an intermediate patient on Syntax. It's a very focal lesion on LAD that is relatively simple to treat, and RCA too. We can do it in a second moment.
So we do around 600 bypass surgeries in this hospital a year, but we need to consider that. And also we do about 2,500 PCI, Dante Pazzanesi, a year. So in a patient like this, I think we should treat because the lesions are not complex and it's a very low syntax. Do you agree?
There is some complexity because the calcification in the RCA, but it's our day we perform this.
So
Dimitri,
in fact, it's what we did last week. So he underwent PCI. with a drug-eluting stent at the mid-LAD, and as you can see here, with a very good result.
Did you protect that small branch, that diagonal branch? Should we do that, Rodolfo? No.
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 In
About
this
you,
case, no,
Dimitri?
because
I don't know
No.
how to perform this case, but
Uh,
it's a small diagonal
okay.
with no osseo lesion.
yeah,
See.
So,
no ocean lesion, no.
Okay.
and you
uh,
can see at the end, the diagonal was there.
the
So do
angle
you
was
think
good.
we could do in even an ACS patient and to proceed the RCA the same procedure?
When we saw the fluoroscopy, right, Rodolfo? You can see now it's very calcified.
Very
vessel.
calcified. Okay.
And then we don't have, for example, devices like intravascular lithotripsy on the shelf. So nowadays we have to schedule those kind of procedures.
So that's very important mention when you say that. So if you can stage this patient, maybe you can have a safer procedure if you're doing separated.
Yeah.
Do you agree with this?
Yeah.
So definitely. So
Totally.
and then Dimitri, what do we have? Rodolfo, what we have
No.
done so far today, please?
Now,
Can you go back with? Okay. Can
Yeah.
you? Great. Thank you. You're so fast.
the RCA,
Thank you. So can you show us the calcium that Dimitri mentioned?
it's
Please,
a very
Rodolfo.
calcified lesion. Both the proximal and the mid portion of the RCA.
The fact is that we can see some calcium, but angiography is very limited to characterize the calcium burden, let's say.
So
We can say that the calcium is superficial or deep, the length of calcification. So we decided to perform intravascular imaging first.
before the pre-dilatation.
And we tried, right, Rodolfo?
Yeah,
But we didn't succeed.
Okay. What kind of wire did you use, Rodolfo?
it's a regular wire, a coil tipped wire.
Non-polymeric.
No polymeric.
Non-polymeric wire. So
cross
so
easily.
So it's
Yeah?
almost
It's
a
more
total
safe
occlusion.
to
Yeah. So you place the wire
Yeah.
distal on the right.
And the
So now you try to
ultrasound-
bring the IVUS catheter.
the IVUS not cross the.
So
the
if you remember in the case in the other room, the case we just do with Ricardo, we could cross with the IVUS catheter, and how we could not. So in the end, we decide to pre-dilate.
yeah, to relate it with a low profile balloon,
Okay.
a
2.0 by 20.
2.0.
Oh no, you change
Yeah.
this
Maybe
the backup
it's maybe,
support.
yeah,
Okay,
maybe.
so
But
so there are 5 lessons here. We need to talk this to the audience. It's very important.
Yeah.
Because sometimes you see someone trying, you can get some trouble if you cannot across. So we start with a non-compliant balloon. If you're not across, you go to a semi-compliant balloon 1.0. If you're not across, if you don't across, you go with a buddy wire. If you don't across, you change your guide support, and then you
then
go
we
to
can
a
try.
special tool.
Yeah.
Okay,
And
great.
if not cross, atherectomy.
Atherectomy, rotablator,
Or ornamental or laser.
laser, both. Okay,
up.
great.
So-
That's a good explanation.
So, Fausto, and then after pre-dilation, we got some images from IVUS. Maybe Ricardo can show to us.
Oh, Ricardo is here. Okay. Did you finish there? It's good.
We finished there and we increased the.
Can you
also
have the
of
camera with
LED.
Ricardo? Could you please look at the camera over there, Ricardo? Up there.
Okay.
Okay, okay.
Okay. Just to
Ricardo
say-
is just in my left here. Please, right here.
Okay.
Ricardo.
Okay.
Okay, Ricardo is here. Okay, good.
Okay. So we're gonna see.
Did you
the
finish?
IVUS.
Did you get a good result over
We
there?
got a good result. The minimum lumen area, the osteon of the LED, the standard LED, was 6.2. We
Great.
increased above 9.
Okay.
So it was excellent result. Maybe we can show
So,
later the
quite
angel.
good. Okay, thank you very much for coming here with
Yeah.
us and help with the IVUS.
Yeah. So you can
Can you have the IVUS image in the screen, the large screen, please? Great. If you can show Ricardo close to the camera, it will be good. If you're not, no problem.
Okay, so we in the very distal to the lesion, to the second lesion in the RCA, we can see it's a very large vessel. It's about 4.0 by 4.5. I'm going to just keep the run here so we can see the entire segment. We already see a calcification here between 3 and 7 o'clock, and we can start to see some more moderate disease, fibro-calcified, which starts to compromise more the lumen here. And that's where we see the tight stenosis, the distal lesion in this mid to distal portion of the RCA. I would say the tightest point is more heavily calcified, but the other proximal and distal segments here, we have some calcification between 9 and 180 degrees. Here will be a landing zone to this distal lesion. We see some acute marginal branches coming at 9 o'clock, heavily calcified, but without compromise of the lumen. Now you can see this less disease segment is not too long. We already start to see the disease that involves the proximal segment. So here's a very large vessel above 5 millimeter in terms of diameter. And we start to see some nodules of calcium between 3 and 5 o'clock. Very nice to see some calcification here and some dissection, appears to be a dissection, a nodule, maybe after the post-dilatation, the pre-dilatation. And now we're gonna come to that spot that we see the tightest stenosis. Here you start to see 270 degrees of calcium. That's one spot. This is actually 360 degrees. We see superficial and deep calcium in this lesion, and more focal, the tightest point. And now the vessel gets very large again, above 5 millimeter in terms of diameter. The calcification remains here. It's fully calcified, but without compromise of the lumen here.
Okay.
Okay.
Okay. Great.
Now we have some mild disease, more in the proximal RCA, but I think we out of the spot of the lesion here.
Could you make a comparison and between the two cases? We just treated one in the lab 4. You could cross with the IVUS catheter, and now Rodolfo tried with the IVUS. The IVUS did not cross. Why? Can you make a comparison with the IVUS finding over there in the lab 4 and IVUS find in this patient?
Yeah, there we saw a more diffuse disease, more calcified disease in terms of extent, but the tightest point was not as severe as we had here. He was a very, very severe subocclusive stenosis, and it was not enough for an IVUS catheter. It was about 2.4 French to pass.
So in other words, this lesion is more severe than that one?
Yes,
Wow.
in terms of stenosis, yes.
Okay. So by angel, we could not say that. Yeah. They are very similar.
So Ricardo, based on these findings, what would you recommend as a device to modify the calcium?
Well,
in this case,
It's a very important question from the meeting. The calcium was superficial or deep in this case?
Yeah.
Compared to that one? Both questions.
Yeah, here in the proximal lesion, you can see a lot of superficial calcium as well as deep calcium, but it's more restrained to the lesion site. It's not so diffuse. As compared to the other, we have more diffuse, both superficial and deep. In the distal lesion here, I don't see as much superficial calcium.
So what's your recommendation, like Dimitri?
So definitely in the proximal lesion, you need some good lesion preparation to achieve a good expansion.
So Rodolfo, can you get this good preparation only with the balloon?
Maybe.
we're gonna try that.
We are trying.
Try with
let's see.
1.1.
What balloon did you use to breed dilation? 2.0, you said.
2.0. And
2.0.
now
Yeah.
we with a 3.5 balloon.
3.5, because it's a large vessel. It's a
Non-compliant,
4.0
yeah.
vessel, at least. So now we are 3.5 balloon, non-compliant balloon. Is that correct? Okay.
Yeah. We have some
Okay, go ahead. Pay attention, and I'm going to talk to Dimitri here while you're working hard over there. So do you think the guide support is okay?
So, Fausto, this is a 7th French.
So now you're using by radio.
Yeah.
If you show the camera here in the radio, Rodolfo is working on the radio. It's very important. We did a femoral case in the other lab, and now we are working the radio. We do about 70%. Is that correct, Dimitri? 70% of radio?
Yeah.
Yeah. And then 70. By radio.
So, that support is not so good.
Fausto, if I can make another comment based on the IVUS.
Oh, please.
We did see here some nodules of calcium that protrude into the main vessel,
I see.
into the coronary vessel.
Also, we have some difficulty to cross the lesion, but now we.
Yeah. Okay. Is there someone make a question to us? Ricardo, please.
Yeah, so basically when we're dealing with IVL, you should try to be in the nominal pressure and to avoid to overextend, even though it's a more compliant balloon, to overextend the vessel and cause some sort of rupture. Also, when you applying this device, it is, I would say, a relatively low profile, but not as low as regular semi-compliant or non-compliant balloons. So the maneuvers when you're advancing and depending on what stage are you in terms of the lesion preparation, you should always also try to be careful. We have had cases that we had to do some extra work to really deploy in the right spot and really have the effect where you wanted to have the lesions. In terms of...
Okay, in other words, the complications depends of your technique. If you do an oversized balloon, you can get a dissection. But if you do an undersized balloon, the complications are rare with IVL. Is that correct?
Exactly. And very, we don't see descriptions of rupturing just to because you're applying the sound wave pressure because you causing the fracture more in the superficial tissue.
So let's see what Rodolfo and Dimitri are doing here.
We have some difficulty to cross the.
What do you did? A special maneuver with the guiding catheter?
Engage more.
Okay, good. With the guide.
Clock rotation.
Okay, good.
So then we predilate at high pressure
with 25 atmospheres in both lesions.
So Dimitri, what modalities are available for calcium evaluation at this time? Can you answer this question? Why Rodolfo? What are you doing now, Rodolfo?
So we got to IVUS
to see. And while Rodolfo is advanced the IVUS catheter, could you answer this question to evaluate calcium?
What do you mean? At the cath lab or as a pre-planning? Because we have CTA, for example.
Yes, CTA,
it's a good tool to evaluate calcium distribution and how severely calcified is the vessel, angulations. So we can perform that before the procedure. And in the cath lab, we can do IVUS or OCT.
So we have here IVUS, maybe if you want to show.
Yeah, can you show the IVUS, please?
IVUS.
In the screen? Please. Okay,
so
great.
We started here in the very distal portion of the RCA after more aggressive predilatation has been performed with a non-compliant balloon, more size to the vessel size, which is a very large vessel. We should be getting here to the spot of the distal lesion. So that's where we start to see the lesion. We start to see some dissections here between 6 and 7. And here, as you don't have about 180 degrees of calcium, that's exactly where the rupture is between the soft and the hard tissue. We just passed that spot. And here it's a quite large vessels we have highlighted. Fully calcified, but without compromise of the lumen at this particular region. Here's in between lesions, the vessel gets really larger. Here's even like an appearance of some ectasia here. There's some nodules of calcium here, as we can see in the upper part between 12 and 2. And depending on the technique for lesion preparation, there are some that could be, there's some more recent data that show benefit as well in achieving a optimal expansion. Here we are at the spot where the proximal lesion is.
So Ricardo,
And
we didn't
just
get
passed that
much
spot,
luminal gain,
and now
right?
it's a good luminal
At
gain, but not,
proximal
not
lesion.
enough.
At
What's
the
that?
proximal lesion, we didn't get so much gain, luminal gain, right?
Yeah, it did call the attention that here we are just at the proximal lesion. See the comparison here between the references, the proximal and the distal reference. Of course, there is some good luminal gain, but not enough for you to really feel confident that you're going to achieve an optimal expansion, even though the area is large. But expansion does not have to do only with the area. You need to do a uniform expansion throughout the stent. And what I see here is also some nodules of calcium, and we don't see a good fragmentation, a cracking of the vessel. We do see some dissections, but not a cracking of the
vessel. So this is a
vessel.
good indication for intravenous lithotripsy,
Oh,
right?
absolutely.
Just to modify calcium to get some fracturing and to modify the compliance of the vessel.
Fracturing, fracturing, and then you get the compliance to full expansion. And if I were to suggest, if you want to do IVL, you should go with a 4.0 by 12 millimeters, because the vessel is really large.
So, and Dimitri, let's, based on your question, so we do have 3 tools to modify calcified plaque. We have laser, we have a rotational atherectomy, and we have IVL, lithotripsy. So, would you have a preference for any type of device to indicate? Can you make any comments? Because I know you do a structure, but you also do
First
a lot
of all, I think that operator experience is an important thing to consider. So if you are...
can you please, sorry, Dimitri, just to close here, the preparation of IVL catheter, please, the shock wave. Can you close here the hands? Okay, good. Go ahead, Dimitri, sorry.
Operator experience it's very important. So if you feel comfortable to go with rotational atherectomy or to IVL, you should go for that. But I think that the calcium characteristics that Ricardo just showed to us, it's very important also to define which device to be used.
I see. Rodolfo, the vessel size should...
Despite the pre-dilatation with a 3.5 balloon,
you have some difficulty to
I have some difficulty to correct position the LIV balloon, because the profile is not low.
Okay. So how about if you improve the backup support? I mean, make like a clockwise
rotation.
Yeah.
A little bit.
Yeah. Oh, please go ahead, please. Ricardo.
You can use IVL without any problem. And the worries here is just to dealing with a dissection. Of course, you're going to have another balloon, which is going to be inflated there, and things might needs to be controlled in that perspective. But doing IVL by itself, it's not a problem.
So what are you doing, Rodolfo, now? You inflate the balloon, just proximal.
The position is not perfect.
Yes.
But it's the maximal.
So you're going to do the shock wave now. Okay. Okay.
Right.
So you're a little bit proximal to the tight lesion. I mean, the tight portion of the lesion, I would say that. And we could see you have some difficulty to across. So if you cannot cross that, do you think we should choose the guide support to like an implants or a body wire, or just stop and go with the stent, Rodolfo?
Let's go to 6 atmosphere here.
Yeah. No, 5, 4 atmospheres.
6.
4. Not necessary.
Yeah, I think that could.
I think that the balloon don't cross the lesion. I have difficult to push.
So what would you change to implants, body wire, or go with the stent?
First body wire.
Body wire. Okay. Let's see again.
4.
Go ahead, please. Go ahead, please.
4. Yes.
Can you say it again, please? Yes, you can do it. I don't think we have studies demonstrating that doing 5 it's you inferior in terms of your final result as doing all the cycles with 8 and getting the 80 pulse. But that's an advice from the company to use as much as you can. As we have seen these cases, these are diffusely diseased and calcified vessels, and once you can have the effect on cracking the vessel throughout people doing less, if it's people doing more, we're more likely to do more. In the last case, we did about 5, and we think it's just good. We achieved what we expected, but there's absolutely no penalty in doing more if the patient tolerates well, and that's usually done. But I think you should control your result by imaging, especially intravascular imaging. In our case that we just did, there was a clearly benefit in terms of luminal gain, in terms of cracking of the calcified plaque, and we felt very comfortable on having just 5.
Okay. Did he answer your question? Okay, another question, please, go ahead.
Yeah, that's a very good question. We don't see as one substituting the other or replacing the other. Maybe in one of other case, but we see them as more complementary. Those lesions that you cannot even pass with a very small balloons, rotablator I think is still the treatment of choice, and we have used here very often in our institution with very good results. But IVL come as an additive tool to those situations that you need to have a more full plaque preparation, cracking of the calcified lesion, and sometimes larger vessel where rotablator does not do well.
So okay, another question. Go ahead, please.
Okay.
What's 6? Espera aí.
6.
Yes. Well, they have different mechanism, and rotablator will be perform very well in more superficial calcium, and IVL it does work well in superficial as well as more deeper calcium, as well as nodules, calcified nodules. We have seen some recent studies demonstrated the benefit in that situation. So as I mentioned, we see them as more potentially complementary than exclusive.
So as you can see here, Rodolfo has been working hard to get across. Now I think he is a little bit distal. You're distal now, Rodolfo?
4.
Yeah, a little bit.
A little bit, but we could not get through that curve in the right with the IVL catheter.
6, 8, foi pouquinho mais a relação.
He did at least 5 or 6 inflations there.
Okay.
And trying to get across with the guider so carefully. Let's see.
Put the guide wire was just.
Okay, now he's placing the wire distally, but it doesn't seem to me we did move ahead with this catheter. Maybe we're going to try another technique to do that. I mean, we feel that the profile of the balloon is
mais de
large,
pressão.
and sometimes we get some difficult to get across the lesion.
10.
So we need to work. So Rodolfo, do you think the stent would go down better than this or not? We should not try.
I try with maybe a 3.5
Non-compliant balloon again?
Yeah, again.
Okay. Could you bring the 3.5, please? 3.5 balloon, non-compliant balloon.
Aquele nosso balãozinho aí.
3,5 por
Tem aqui.
15, não complacente.
Pode ser, nós temos aí. Vamos tentar esse.
So you did a pre-dilatation
We have
with
one here,
a 3.5 by... You use a 3.5 already.
Let do
Again,
to
high pressure.
more pressure, more
So
high
what
pressure.
pressure did you use in that pre-dilatation? 20?
25.
25.
But,
You already
well,
used the 25?
27, 30.
And now you're going up
atmospheres.
to 25.
Yeah,
But
and to check that the balloon, I use balloon
okay.
cross the lesion.
The lesion, great.
Balloon, if the balloon cross, the stent will cross.
Okay, okay, good. Let's see with the balloon.
It's a test.
So calcified lesions are really a predictor for unsuccessful treatment with PCI. And Ricardo, how can we quantify with IVUS or even OCT? Is that possible to compare the two methods, IVUS and OCT, to quantify calcified lesions?
Yes, there is a rule of 5 that has been validated as a predictor, and that includes up to 5 millimeters or more calcium in the circumferential measure, in depth or the thickness more than 0.5, and also covering more than 50% of the circumferential plaque. If you have these 3 predictors all together, then you're more likely to have difficulties on achieving a good result in terms of optimal stent implantation and expansion.
Okay.
OCT has one advantage, because you can actually measure the area, you can trace the area, you can see the full deepness of the calcified plaque. Because IVUS use wave sounds, you cannot see you cannot see the depth of the plaque.
Okay, great. Now Rodolfo is use
The balloon cross, I think the stent will cross.
Do you think you should go with the stent or come back with the IVL catheter now?
No, I think they have a little
So
bit
do
difficult.
you think the IVL did a work on the plaque or not?
Yes, stent.
Can you check with the IVUS?
Maybe. IVUS, please.
So Rodolfo did just reviewing the case. Rodolfo
Fazer
did
essa na proximal.
a pre-dilatation, and it came with the IVUS, showed a lot of calcium, as Ricardo mentioned to you.
Balão
And
375,
he came
15.
with a 3.5 balloon, non-compliant,
Passa, Rodolfo.
to predilate a little bit more
IVUS.
after IVUS catheter, brought the IVL catheter that could not cross completely the lesion, was only the proximal part of the lesion, tried many times with shock wave application, and he did that, and now he brought a 3.5 balloon again, 3.5, and did another dilatation with a 25 or 26 atmospheres. 27 atmosphere, and now he's going to bring the IVUS just to take a look in the lumen and to decide what to do. Again with the shock wave, a little bit more trying, or go with the stent implantation. So that's what do we do in the calcified lesion. Sometimes we need to work pretty hard to do a procedure like this. So now he's bringing the IVUS catheter,
Here.
as you can mention there.
Pull back.
Okay, so we started more in the proximal.
May you have the IVUS in the
Lesion
large
here.
screen? Great, thank you.
So just in the mid portion, that's where we have a landing zone here. It's fully calcified, but not compromising the lumen. Now we see coming to the plaque site. There's some luminal gain here. We see a dissection there at 12. We see this calcified plaque, protruding here. We see still a compromise of lumen here. when we have stent implantation, we see a result like this. There's acute recoil involved here, but definitely some luminal gain. But at the plaque site, we still see compromised lumen, and that calcification is playing a role there.
Balão
Do you
4-0.
think there are some
Balão 4x15.
calcium fractures?
I do see. We could see some plaque fracture. I can get back here to show.
Yeah. I think it's important just to Rodolfo try to make his decision now.
Yeah, you see here a dissection here just at 9 o'clock. And then as you come here, so you see the flap here. It's very nicely demonstrated here. You can have this tool here in the Boston system that you can see moving, so you know what's the bloodstream and what is the plaque here. And you can see the flap and 180 degrees of calcium.
Okay. And how about the calcium? Did you see any modification in the calcium?
Yeah. And here, that's where we see. You see here the discontinuity here, the cracking of the calcified plaque, and you do have some gain, but it's still elliptical because of the role that this hard tissue plays here. And
so the decision here is going to go with the stent.
Another balloon. 4-0.
4-0. So Rodolfo is working hard. So why don't you come with a stent right now? Is there any explanation for this? Why do you choose a balloon?
Because when I try to recross with the
IVL
balloon, did not cross.
So now you're using a 4-0 balloon.
Yeah.
Do you agree, Ricardo?
Yes, I do agree. I just measured
you have
here.
your room? Okay, good.
Yeah, enough room for that.
Yes. It's a 5-0 vessel.
Yeah, it's a close to 5-0 vessel.
Okay, good. Now Rodolfo brought a 4-0 balloon. 4-0 by 15 or 8?
15.
15. 4-0 by 15 non-compliant balloon.
Can I have the angel, please?
Angel, please. Okay.
25.
Okay, great. Thank you. Now with 25 atmospheres. So we still see some constriction there. You cannot open perfectly. So we have a 4-0 balloon, 25 atmospheres, and not fully expanded. So do you think that it's worth to bring it the IVL catheter again or not? No. So it's really hard. Even after you deflate the balloon, you cannot get across there.
The calcium nodule.
Yeah, and the support is not perfect, I think.
Yeah, I agree.
De novo, sobe, pressão.
So if you cannot cross like you did this test, sometimes they stent has some problem to get down.
Okay. You can use a modern charge technique.
So if you change your tools here, so if you, for example, if you're going to use a rotablade burr, you need a larger one. Is that correct, Rodolfo? If you use a rotablator?
Now?
Yeah. If you cannot cross it with the balloon or with the stent.
The vessel is too large, right?
Então, that's my question. The burr, a 2.5 burr. So you're going to try with the stent now.
Yeah.
Yeah. Good. What size of stent in a
4.0 by 26.
26. 4.0 by 26. 4.0 by 26.
O Ciro aí 4.26 tá na mão.
4.26.
Yes.
Abre, por favor.
Or Ciro again. Okay.
E deixa o ST01 na mão aí, Zé.
Let's see. So Ricardo, could you make any comment about this? So in your case, in the lab 4, we could go easily with the IVL catheter. Would you expect that you could not cross with the IVL catheter in this case?
Yeah, I think even though it did not compromise the luminal proximal segment, but the degree of calcification in the inner wall, we do see sometimes it's difficult to advance anything.
Okay.
So that's the problem with the calcified lesions and vessels.
Okay. So now let's pay attention in Rodolfo work here with Dimitri. They are bringing a 4.0 by 26 corner stent. It's or 01.
Yeah.
Is
very thin stent to.
Yeah, very thin strut. It's a good option.
Low profile.
After you're seeing this, do you think we should use an implants guide since the beginning or not?
I'm not sure because the takeoff the RCA is good.
I see.
Inferior. clockwise rotation.
Okay, you're doing a clockwise to get a better guide support.
Okay. VHW.
So although we did a pre-dilatation with a 4O balloon,
pra gente.
4O balloon,
VHW.
now we are going to try the body wire just to see if it's okay. Sometimes maybe we should change everything and place an implants guide. So we still have 10 minutes, not hurry, but that's a calcified lesion. That was they asked us to try. You need to work hard
VH?
on this. So should you try to bring the shock wave before and try to open a little bit or not at this point?
I use a body wire technique.
But with a shock wave?
No.
No shock wave. Only with the stent.
Only.
So, but could it be to use the shock wave with a body wire or not?
Yeah, but
Just to,
I think it's not
to do a better work on the plaque.
result.
I think it's a possibility if you can cross with a body wire and bring the shock wave just to work a little bit in this lesion. So this is the BHW.
VHW.
It's a high support guide wire.
E não vai mais.
É nele não quer no...
So are you using a 7-French guide, a GR4, JR4?
JR4.
Yeah.
Quer no BM ou no BH?
BH?
Let's see. Let's see if the body wire can help us to cross this lesion.
BH, hein?
Ricardo, would you use IVL at this point or would you use a stent? Coronary stent?
I think you could get some benefits of preparing the lesion more optimal. So I think the IVL goes down. I think that could benefit.
Okay.
Yeah.
And how about that guide support? That Guidezilla or something like this? Would be a
that could also be an option to have.
Have you used
the
IVL catheter in a Guidezilla?
I haven't, but
No.
but that could be used.
Okay. Do we have Guidezilla here? Just to have here. Let's see if Rodolfo is want to use this.
Then it cross.
No.
Acho que é Godzilla.
Godzilla.
Ou ST01.
What Godzilla?
Or ST.
Abre.
Yeah.
Which one? Yeah.
So this is like a modern
tirar.
child support.
Okay.
Yeah, we can. It's always helpful.
Vou colocar o ST.
Deixa eu ver o nome disso aí.
Tirar, né?
Heart Trail.
Tira.
ST01.
Vamos lá. Tá na mão aí? Vai.
Yeah,
Okay,
and I think Fausto just highlights that when you're dealing with very calcified lesions, multiple tools are needed, right?
Oh yeah.
To really.
Yes. Yes, please go ahead.
Yes, we do. It's just to apply that is just like performing a balloon dilatation. So this is very user friendly. Of course, this type of lesions, they are not user friendly. So you gotta make room for these lesions when needed to deploy that. But the technology itself is very user friendly. Absolutely. and that speaks for the usage, which is
balão
close to
3,5 novo.
100,000 procedures in the world, and
3,5 novo.
in Brazil
Quantos são
we're close to
3,015?
1,000 procedures. So
Só para a gente
It's really
poder descer. Tem que fazer
a
âncora.
very fast and
Balão 3,5.
impressive incorporation into clinical practice.
Balão 3,5 aí. Pode ser de pré.
So
Só pra
Rodolfo,
fazer o-
using like a modern and child, right?
Yeah.
Technique.
Yeah, we're gonna try the anchor technique just to put the device down and then try to go with the stent.
Okay.
So now Rodolfo is bringing a 3.5 balloon, a 3.5 by 15.
O balão é quanto? Quanto que é o balão? 3.5 by 15.
Okay, good.
Just
3.5 by
to,
15.
to help the
Just to do
support
the balloon
the cutter.
anchoring.
Huh?
to perform anchoring and cross
Okay,
The-
let's see.
the segment. Right.
So the balloon is distal,
Yeah.
and he's advancing
Yeah.
the catheter now. Is that right? Okay, good.
Yeah.
Okay.
Oh,
Or even with the
Não,
catheter.
peguei,
Yeah.
talvez.
Okay.
it's a very elegant
problem is solved.
demonstration.
Oh, yeah.
Stent now.
So doesn't it worth to be work with
Okay.
IVL
Stage.
now? No,
No.
the stent.
Stent.
Okay, we are gonna be finishing in 5 minutes now with the mother and child catheter. This is from Terumo. What's the name of this one? It's
ST.
ST01.
ST01.
ST01. ST0, but there is another name I saw. Where can that Terumo?
Pode colocar aí.
Let's show it. From Terumo. The mother and child. Yes. Can you show
Vai
it?
precisar
Heart
de
Trail ST01.
plantar
Good.
esse distal e depois deixar ele lá, né?
Which
Can
is
you
an
show, Renata, can you please show here? Let me show them here. It's not an advertisement, but we need to show, because sometimes we talk about Guidezilla. Can you just show there? Here. Can you bring the camera here? Yeah. Outside? That's okay. We show later.
Yeah, so it went very smoothly.
So the stent is down now.
Okay.
So we are going to treat the
Test.
distal lesion.
Show.
We have the catheter there.
Um pouquinho para trás.
And now
Ok. O negócio perdeu.
we are inflating.
Aí. Sobe.
Okay, we still have 3 minutes
Vai, vai.
to finish. So this is 4.0 by 26. Is that correct?
Ok.
Okay. 4.0 by 26 went up to
14 atmosphere.
14 atmospheres. That mother and child and ST01, it was very
Tá bom.
helpful.
Outro
to
stent
across the
desse aí,
lesion.
426.
Mais um 426.
Very elegant demonstration of this technique.
Oh yes.
After nothing went down, you just put the
Yes,
cutter down and you
yes.
can
Guia lá, aqui.
deliver anything you want
Yeah.
there.
Guia lá.
Yeah. It's really a good solution.
BMW. It's necessary know the technologies, né?
Yeah, no,
The
it's
tricks,
very important to see this.
and have the material.
Have calcification.
With
Yes, we need to have everything
in
here. The
scenarios
tools.
of
We need to have the tools close to you.
tips and tricks
Yeah.
and the tools.
So we are going to finish in 2 minutes. Is that correct? Can you tell me, please? 2 minutes? 2 more minutes or not? Que horas são?
Bomba.
Não, no seu aqui. Okay, 1 minute. Okay. Let's see.
Yeah, and we have seen also some cases that even if you cannot go too deep into the,
Yeah.
the distal portion, the IVL in any calcified region can make a difference in helping making room to
Yes.
Teste.
further treatments.
Teste.
Yeah, Rodolfo is so careful to cover all
Teste.
the place where he inflate the balloon, the proximal part of the lesion.
Mais um teste
Yeah,
para ver proximal.
Yes.
Teste.
Nota bem.
Okay.
Ok. Sobe.
Could you say
Sobe.
again, please?
Vai. 10, 12, mais.
O que ele falou, Ricardo?
16.
Tá bom. Vinsel.
Okay, we are gonna be finished now, and just to see the final result by Angel. And you do IVUS, but it's fine. So this is a heavy calcified lesion that was treated with predilation, IVL catheter, IVUS, and also finishing with
good.
a mother and child
Okay.
technique. I think we are quite satisfied with this. And Rodolfo, can you have the camera now with everyone here? Just to, we're going to finish now. It's time to finish the 2 hours live transmission from Brazil. May you have the camera for everybody here, please? Yes, great. So we have this beautiful team here, and I need to thank Rodolfo, my friend Rodolfo, from the coronary intervention. He's the chief. Dimitri from structure, Jose Henrique, Ricardo, who answered these questions and did the IVUS, and all the technicians, the people from Shockwave. Thank you very much that came here, bring the monitor, all the anesthesiology, and the very wonderful people from the nurse team that we have here. So thank you so much,
Thank you.
and see you next Wednesday. Bye-bye.
Vai.
Right.